Welcome to This Medical Life podcast. These are the stories of medicine with Steve Davis and Dr. Travis Brown.
This is the story of Scleroderma.
Dr. Travis Brown, sometimes you say I'm a little bit thin-skinned, and so that's why Scleroderma is a nice way to sort of balance things up.
I would never say you were thin-skinned, but this is the story of Scleroderma. So, look, it actually reaches back into my medical school days, this one. And I remember doing ward rounds as a medical student, and often these can be overwhelming times when you're doing ward rounds because you can see so many different people. You're in an environment that's busy, working, you feel like you're an appendage because you're a medical student trying to learn. You actually have no role other than learning, so sometimes you feel you're in your way. But I remember seeing this patient, and I'd actually missed what the doctor had said about it and said about what we were going to see with this patient. So I missed what the diagnosis was. And then we walk into this room with a patient, and turns out she was about a 60-year-old patient, but she looked about 40. And so she had this really tight skin, and I thought she just didn't look right. The skin looked actually quite shiny. She didn't have any expression, and she didn't have, like, eyebrows. And I was like, has she been burnt or something like that? And it turns out as we were examining, the doctor talked about, well, look, if you feel her skin, actually it was quite thick, and she had like no wrinkles or anything that you could say. She actually looked 40. And it didn't make sense to me until years later when I was actually studying and I came across what she had was Scleroderma. And now this is a thickening of the skin. This is there's different subsets. So there's something called diffuse. There is systemic sclerosis, where it can not only affect the skin, but it can affect organs. Now, the reason why I mention this is because I also remember I was doing blood taking at the time, and she was really hard to take blood from.
Oh, because the needle has to get its way through.
And it's really thick skin. And so this is actually where we see, when we look at historically, there are actually glimpses of this disease throughout it. Now, again, this falls into a whole broad range of categories that you're talking about skin. So you can never really quite take your sort of microscope really and say, well, this is exactly what they're talking about here. But there are some glimpses. And again, this is quite a rare disease. There are different forms, and one is sort of a localized kind of hardening area of skin. One is diffuse that affects organs as well as skin. But there is a glimpse. One example is from Galen, who wrote about something called constriction of the pores.
As soon as the patients undress, from the white pallor and hardness and thickness of the skin, and during exercise by their difficulty in warming up.
We've got this, again, is he talking about the same disease? Hard to say. But when we get to the 17th century, we get descriptions that are more detailed. Some things are more convincing of this disease. And there is one person who's a Dutch physician, and hopefully I don't butcher his name too much, but it's Isbrandus van Dijvenbroek. And he wrote about this of one of his patients.
She had skin what was hard, like the taut membrane of a war drum, and also rather cold, and yet she had no sense of touch, so that if she were struck with pins, or if fire were applied to her, she had no sense of hurt or pain therefrom. But if she were punctured more deeply by a pin or needle down to some underlying muscle, then right away she felt a deep pain in the muscle.
Our first medical description that we can attribute is to Dr. Carlo Cusio, and he wrote about a 17-year-old woman, and this was published in 1750s.
Her complaint was an excessive tension and hardness of her skin all over her body, by which she found herself so bound and straightened that she could hardly move her limbs. Her skin was hard to touch, like wood or a dry hide. However, there was some difference in the degree of hardness, but the muscles under the skin seemed not to be affected. The hardness and tension of the skin did not yield to their contraction or relaxation. Her skin had lost its natural warmth. Her pulse was perceived to be deep and obscure, but equal and regular. Her respiration was free and uninterrupted. Her digestion was good, and she found no inconvenience after eating, except a greater straightness and an uneasy constriction round the belly.
And this is why I really enjoy these historical descriptions, is because they actually go into quite a lot of depth and detail, because they know they're piecing something together, but they haven't quite got how it all fits. And look, this was the 1700s. She was treated with warm milk, vapor baths, small doses of quicksilver, which I'm not exactly sure what quicksilver is, but and bleeding. They've got phlebotomy, but they had to bleed her from her foot because they couldn't get good access elsewhere, because it was those times. And look, you start to see the jigsaw come together over time. In the 19th century, they talk about an association with cutaneous calcinosis. So that's calcium deposition within the skin. In the 1854, we have the first recorded description of this localised, this circumscribed version, now we call it morphea, by Dr. Thomas Edison.
This condition is first indicated by a white patch or opacity of the integument of a roundish or oval shape, and varying in size from that of a silver penny or crown piece, very slightly elevated above the level of the surrounding skin. A more or less vivid zone of redness surrounding the whole patch, or a certain amount of venous congestion. It begins to declare itself by a feeling of itching pain, a tightness or constriction of the affected part. If extensive, it may become so tightened, fixed, and rigid as to be no longer capable of performing their proper functions. But especially the fingers may be permanently contracted, bent, and rendered almost as hard, as immovable as a piece of wood.
And this brings us to the last quote, and this is from Dr. Maurice Raynaud, who around the same time described what we call today Raynaud's phenomenon.
In the space of an hour, we see the fingers change colour several times, the dominant one being a shade of pale greenish grey. But at times, for example in the morning, when the patient has just got up, or under the influence of cold, the hands and wrists take on a blackish colour, which the patient compares, with a little exaggeration no doubt, to the dripping of his coat.
You can see this disease, this scleroderma, has many facets. It has different subsets. And so all the puzzles are sort of coming together, and you're seeing effectively medical detective work of how does this disease occur? How does we have it sometimes in patches, sometimes we have it full body. We also know today that if we talk about the diffuse sclerosis, we're looking we're looking at things like, yes, it can actually affect. The most obvious is skin, but it can affect the musculoskeletal system with regards to arthritis, tendinitis. It can also have an effect of neuromuscular effects, but 90% of the patients who have the diffuse type will actually have gastrointestinal involvement, but half of them are asymptomatic. Over 80%, will have lung involvement, so they can have things like breathlessness and a non-productive cough. 60 to 80% will have a kidney disease or kidney damage. And there's also cardiac and genitourinary symptoms that they will have. So this is really a devastating disease. And that's why we've got our guests along to understand this, but we do have treatment, we do have management, but it is quite rare, and this is why podcast is a beautiful place to present this, which is a disease, again, even in medical student, I didn't understand. It wasn't until studying much later that I got a grip of that. And this can be actually difficult to diagnose. And that's why we've got this today.
Well, thank goodness, since that time, getting diagnoses wrong now, you've got a thick skin. Dr. Daman Langguth is a clinical and laboratory immunologist. He works at Wesley Hospital as well as Sullivan Nicolaides Pathology in Brisbane. Daman has an extensive research background and is widely published. He's a fellow of the Australian Rheumatology Association, Australasian Society of Clinical Immunology, the RCPA and the RACP. Dr. Langguth has particular expertise in the investigation of autoimmune disease, allergy and immune deficiency, and he is a regular guest on This Medical Life podcast. Daman, welcome back.
Thanks very much. Glad to be here.
Daman, let's dive in by asking you to define what is scleroderma.
Well, we actually don't use that term. Well, it's a common term now, so we renamed it progressive systemic sclerosis. And there's a widespread version and a limited version. And we recognise those are two distinct entities, so there's a bit of crossover. Usually one doesn't progress to the other, so you don't start out limited and move on to progressive. Obviously, all diseases start out relatively limited, but we don't use that term. So it's a disease of dermal fibrosis, so skin fibrosis, scarring of the skin. And so we think this is an induced response. We don't know why you get it. We don't know a lot about what incites it, but it occurs and leads to contractures, tightening of the skin, and can involve as little as just the hands to the entire body.
Whilst we have a limited form and a diffuse form, do we believe this is the same disease, or are these completely separate, do you think?
I think we think they're the same diseases, just in a different form. So a form frust, as my favourite term is. Lots of our autoimmune diseases have variations. They might have the same pathology, but they look quite different. And certainly we know that some people with the limited version or some people with the limited version with the antibody associated with it get severe disease. And so there's a fair bit of crossover. While we say, you've got this antibody called centromere antibody or CenPB, you're going to have a limited disease, about 10% don't. Like in all things immunology, we like to keep it confusing, and we make sure that there are no rules so that only immunologists can do immunology.
Do we know the pathogenesis of this disease? Is it the antibody causing direct damage to the dermal collagen?
Almost certainly not. We don't know the exact, in fact, we're a long way from knowing the exact pathology or pathophysiology of this disease. There is some data which I think is probably correct, and this is very much my opinion. It's other people's opinions as well, but it's not the truth, that it might be a disorder of endothelial cell maturation. So in other words, when the cells lining the blood vessels die or come to maturity, they trigger an immune response locally in fibroblasts. So it might be that the fibroblasts, these cells that make ground substance, they just make all the tissue support. It might be that the disease is in them. And because there's evidence of abnormal proliferation in those cells. And then the antibodies may form by the fact that you get overproduction or underproduction of certain proteins.
Can I just interject as a layperson here? If I didn't have years of doing This Medical Life, I'd be looking back thinking, we don't know very much. Why do we even persist? But of course, I've learned that the nature of medicine is we do keep prodding, we do keep prying. But is there a reason this is in such a vague understanding? Is it just hard to...
It's a rare disease.
Right, okay. So we don't have enough exposure to it to form great...
No, it's very hard to get very large series of it.
When we're looking at who is at risk of this disease, who has the greatest risk profile of getting these diseases?
It's usually women, 20 to 40, usually at the younger end of that range, but anybody can get it.
Right, okay. What do they often present with? I know that's going to be sort of almost a few different answers because we're talking about local and diffuse, but is there a classic presentation for both?
Classic presentation would be having Raynaud's phenomena. So that's when your hands have a classic tricolour change. Firstly, they go blue, and now maybe one finger at a time, not all fingers at a time, but they would go blue and then white, as in completely white. So I can try and show you, as in that kind of white. And they might stay like that for up to, well, they can stay like that for a day, but usually for an hour or two. That's actually not painful. What's painful is when the blood comes back. So that's arterial vasospasm. And so the blood vessels spasm, completely shut off. That's why your finger goes white. And then when the blood comes back in, it's red because it rushes all back in. And that's when it's exceedingly painful. So that's pretty much the same. The last two parts are the same as frostbite. So if anyone's been so cold as your hands have gone into spasm, gone blue from the cold, personally, once on a ski lift with my brother when I was about, I think, probably 15, the lift broke in New Zealand. We were in high winds. I don't know what the temperature was, but it wasn't warm. And at the end, we got off and both our hands were blue, completely blue.
Is Raynaud's phenomenon, is that a risk factor or is that an association or is that...
No, it's not a risk factor per se because the vast majority of people with Raynaud's phenomena are never going to have scleroderma.
Right.
So that just happens to be part of the sclerodermatous complex. We don't really... And that kind of sort of lends ideas that blood vessel disorder in a way is linked to the development of scleroderma. We don't know what it is that are the extra factors that say if you have a Raynaud's phenomena, you might go on, apart from some antibodies. But we don't recommend screening all people with Raynaud's phenomena at all. Right. Because the nature of the tests are that they are very sensitive. And if you use them in a normal population, you'll lose specificity. So in other words, you'll find people with antibodies that aren't going to get disease. Right. And all we do is scare people, and then we don't really know what to do. We subject them to yearly tests, and usually after about 2 or 3 years, people get bored of that and don't do them anymore. And by people, the patients, because nothing's happening.
Putting Raynaud's aside, what else will they present with?
Sort of woody, shiny skin in their hands. So it's called woody edema, and so your fingers get thick. And that's usually present all the time. That's not an intermittent thing. People take a while to realise they all just blame it on all sorts of things because it's obviously a very unusual thing. And until their hands start to get tight, they won't do anything. Because it's such unusual. People just think, I slept on my back funny or I've got tight arms. The other ways it can present is some people can even get scleroderma, sine scleroderma, which sine is Latin for without. And so that is a super rare disorder. And so they present with sclerodermatous involvement of organs but have no skin involvement. Obviously, that's pretty hard to diagnose until things are spectacularly bad.
I would like to withdraw my previous question. This is so hard.
It is difficult. So are you able to distinguish between local and diffuse on the presentation, or is it just an association?
Well, it depends how long the presentation's gone on for. If you live in the country and you don't get to see your GP, or you're a farmer and you can't, as you know, farmers can't ever leave the land. Yeah. And that's not entirely true, but they usually find it difficult too, especially dairy farmers. Cattle farmers are a bit easier, but dairy farmers are very difficult. If they come in 6 months after it started, you can easily tell. Usually it's just monitoring, and then some people have what look like minimal disease, and then suddenly it takes off. Usually that's within the first couple of years. Occasionally, it can be 10 years later, but that's uncommon. But there are a whole range of possibilities, which means you have to keep in contact with people a long time.
If someone's seeing a patient and this actually crops up in their mind, is there any red flag features that they can't miss with this diagnosis?
If the patient has calcinosis, so that is where you get calcium deposits in the skin. That usually occurs in the limited version of the disease. And is part of the acronym CREST. So we used to use that called CREST syndrome. We now just call it limited systemic sclerosis. And CREST, the letters stand for calcinosis, Raynaud's, esophageal dysmotility. In other words, when you swallow, it's painful or difficult, or you get bad reflux. S stands for sclerosis and T stands for telangiectasia, which are sort of windy, broken blood vessels, a bit like people would know spider blood vessels, but these are different. And they usually occur on the face and hands, but can occur all over the body. Now, most people don't have all of those, so it's but the calcinosis part, you can't miss. I saw a patient who had 10 years of calcinosis, and no one twigged to the fact that he had limited systemic sclerosis. Now, in a way, it kind of didn't really matter because we don't treat limited systemic sclerosis because there's no effective treatment for it. We treat the symptoms, but we don't treat the underlying disease. And in fact, in systemic sclerosis, we don't treat that unless it's rapidly progressive because we know our treatments aren't very effective unless the disease is rapidly progressive.
I came across a few, and you've mentioned one, the Scleroderma, but there's also systemic sclerosis overlap syndrome. And how do these all fit?
That's a bit contentious, and it might just be that there's a few views on those. I'm not really sure they are overlap. I think you're just unlucky enough to get two different diseases because that happens. And they might have the same genetic background or risk factors. Not that we know many risk factors for autoimmune disease. I mean, things like smoking, being overweight, family history, not so much, but it is. If you've got 10 members of your family who all have different autoimmune diseases, you're probably more likely to get an autoimmune disease than them. We know that all races get autoimmune diseases. They get them at different frequencies. And so some have names like, and not related to scleroderma, Takayasu's arteritis. So not surprisingly, that was discovered by a Japanese man or first described by a Japanese man. And then originally thought to be largely Japanese disease. But in fact, all of Southeast Asia have a greatly increased frequency, and particularly India. And we know about India because they have a relatively developed healthcare system compared to other places in Southeast Asia. We also know that with that disease, Pacific Islanders seem to have an increased risk because they are, of course, Southeast Asian originally, just about 2,000 to 4,000 years ago, so not that far ago. And they migrated across the Pacific, originally way over to Tahiti and then backwards across down to New Zealand at about 1000 AD.
I just want to come back to Raynaud's phenomenon.
Yep.
How strongly associated is Raynaud's with like the Scleroderma? Is this something that we need to actually say, look, as soon as the patient mentions some of these symptoms that they're, sore hands or presentation, this needs to crop up, or is it not that strong?
I just think, anyone who comes in who's got Raynaud's bad enough that they go to their GP, because most people will just put up with it because they'll either have a family member with it or a friend with it, and they'll go, oh, that's this. They might not use the term, but they'll just go, oh, well. And so if it's not bad, you're not going to see your GP or mention it because you'll go there for something else and you've totally forgotten about it because it's not, and particularly it occurs in winter when it's cold. So that tends to trigger the disease. So if it's not cold, like I would say almost 100% of the time in Queensland, but I'm so acclimatised now that this morning I think it was about 17 degrees and I almost put the duvet on.
Yes.
But you see people who have a temperature change can trigger it as well. So going into the supermarket, you know how when you first go into the supermarket, it's the coldest area because they put the fresh fruit and produce there because that apparently smells nice and then entices you into the store. And then you put the staples at the back because you have to get them. And that way you have to walk through the whole store and you buy stuff on the way. So people walk in there and then their hands spasm. And when they get, that happens enough times, they'll go and see someone. But you just need to look at their hands. It's very hard. For a general practitioner to diagnose scleroderma early, that's really difficult. The signs are subtle. And sometimes, when you see myself, you go, oh, could be, could not be, and you just have to wait. But you know that as long as you're doing careful observation, you're unlikely to lose the chance to treat the patient. About 90% of people have Raynaud's before scleroderma. And if you haven't developed scleroderma by about 7 years after you've developed Raynaud's phenomena, almost certainly you're not going to develop scleroderma. But as I said at the start, the vast majority of people, no idea what the percentage is because we don't know, but the vast majority of people with Raynaud's phenomena are not going to get scleroderma. So we don't really want to scare them and make them have tests. It's just observation. If your hands get thick and swollen, come and see me.
All right. Well, look, let's just pause briefly and we'll come back to look at the testing and the management for scleroderma and give you a chance to go and grab a cardigan, Daman, if it's only 17 degrees. We're continuing now our discussion with Dr. Daman Langguth. And Daman, let's start this section by looking at what the most useful tests are for patients, clinical laboratory tests.
So if you're suspecting scleroderma, we do a test called an ANA, so anti-nuclear antibody. And so we take the patient's blood, we spin it down, so we're just taking the serum, the stuff that's not blood cells, and we dilute that and we put it on cells, and we then stain them and we look for various patterns. And in systemic disease, the most common pattern is what's called a nucleolar pattern. So that's inside the cell. Inside the nucleus of the cell is the nucleolus, in other words, a small nucleus. And that pattern looks very strongly. Some of them look like cat footprints. And so there are a few common patterns. There's also a pattern called centromere. It's pretty hard to describe, but it's classic when you see it. And that's what you do when you're trained as an immunologist. You look at slides. As a registrar, I used to look at 200 slides every morning. It sounds like it takes a long time, but you get it down to about less than 5 seconds a slide. In fact, I used to try and race as quickly as you can. And now in our lab, we actually no longer have to write stuff down. We just click on the screen and say, this is this pattern. And the best thing about our lab is we store every single pattern forever.
Wow.
So we take a photo, and we've done that for about 9 years. So we can look back. And so the best thing is then you can check that you didn't make a mistake. And if someone says, oh, is it really this pattern? Because that would be unusual. And you look back and sometimes you realise that it was a bit dubious whether it was that pattern or not. And you can revise that. But it's nice to be able to look back and make sure, and you can look at history. So when they come in again, and we don't recommend people have ANAs repeated. It's very rare that the pattern ever changes and that the concentration or titer of the ANA is not that relevant. And it's certainly, you cannot use it to monitor disease. So once someone's got, say, a centromere ANA, you really should never have to have it again because it's not going away and there's nothing more you can find out about it.
When a doctor is looking at a report, there will actually be of an ANA test. It will actually say centromere pattern. And so what should that flag for? Is that sensitive or is that specific or is that really useful?
Well, it's very sensitive. The vast majority of people with limited systemic sclerosis have centromere antibodies. It's pretty specific. But when we say that, it depends if you're looking at a normal population. Because I'm not aware of any normal population studies. I think there are some, but I'm not aware of what they had. But I've seen quite a few people, usually young women, with Raynaud's phenomena who have centromere antibodies, but no evidence of scleroderma whatsoever. So I suspect, like most of our tests, or many of these tests in immunology, which are very subjective, that there are a lot of people who do not develop disease who have these. Because, as I said, we don't think they're disease causing. They're disease associated. So you should only do it if you think the patient has scleroderma.
There was a test I came across, but it was under ENA testing,
Yep.
and that was the CENT-B
Yep.
antibody.
Yep.
And it came with actually quite a nice description saying, actually, this is quite sensitive and specific for scleroderma. And I'm trying to work out, is that when someone should be referred and say, you need to see an immunologist? Because it actually says a progression.
Yeah, I think you should be referred to a rheumatologist or an immunologist with an interest in scleroderma. That's most people. And if you are either centromere or SNPB, the chance that they occur without each other is exceptionally low. They're nearly universally reported together because the centromere pattern is what SNPB antibodies detected by a different method give.
Is it common that they can have it and not have the disease?
Yeah, it's not uncommon. Let's put it that way. So it's very hard. When you talk about common and uncommon, we're talking about a disease which is sort of 50 to 300 per million.
Wow.
So it's not common.
Yeah.
So when we say, oh, yeah, that's common, nothing is common.
Yeah.
And what's common to an immunologist is not what's common to a general practitioner, and certainly not what's common to the lay public.
Yeah.
I think if a general practitioner usually has about 700 to 2,000 patients, depends. If they have one person with scleroderma every 10 years, I think that would be probably above average.
Yeah.
So you can imagine trying to diagnose something you only see once every 10 years, or in fact never for a lot of the time.
Now, considering this often will present with skin issues or thickening, is a skin biopsy ever useful?
Look, it can be, but usually when we're thinking about other disorders where we're not sure it's scleroderma, and there are a couple of mimics of scleroderma. One is eosinophilic fasciitis, which is, when I say rare, I don't know, maybe 1 in 10 million. Yeah. And I've seen 5. But that's because I deal with like really rare diseases, and people get me to give second opinions, which is why I get to see more of these things. Yeah. But you can imagine, as a super specialist, and I mean super not in the great version, but in the seeing rare stuff. I've only seen 5, and that's in my career of as a specialist 17 years. So it's rare. And then there's a disorder called morphea, and that can be localised or systemic. And then there's a rare version of that called subcutaneous morphea, which I have seen one of. In fact, and a skin biopsy was very useful in that. Most of the time, you don't need to do skin biopsies. It's pretty obvious what the patient has.
Yeah. Aside from the diagnostic purposes of trying to get what the disease is there any routine tests that are important for monitoring these patients?
Yes. So in most patients, or nearly all patients, we would subject them to yearly lung function testing. So that's where they go to a respiratory lab and they breathe in this little sort of plastic box. It looks a bit weird. I can't really describe it, but it basically measures your lung capacity. And also it looks at whether you might have developed pulmonary hypertension. So that's high blood pressure going to the lungs, as opposed to hypertension, which is high blood pressure, which you can measure by the cuff on your arm. And we also do what's called a NT-proBNP, which is a brain natriuretic peptide. It's a protein secreted by the heart, more on the left side than the right, but both sides, and it controls sodium. And if you control sodium, you control water. We know that elevations in it, classically seen in standard heart failure with the left ventricle, the left side of the heart doesn't pump properly, but also the right side can have elevations, and we use that as a screening tool, and we do that once a year. We usually, at the start, would do a CT scan of the lungs, but we don't use screening for that, just exposes people to a lot of radiation, and we're looking for any fibrosis. Obviously, if people get short of breath, then we change, and that's not, then it's investigation. Some people may or may not do an echocardiogram, but the recommendations at the moment for screening for pulmonary hypertension by the Australian Rheumatology Association are yearly NT-proBNP and lung function testing.
Now, you mentioned it before, but I sort of want to come back to that. What is the treatment for patients?
So in those patients who are progressing, i.e. not limited disease, those people usually just have finger involvement not beyond the wrist. And they usually don't have such severe involvement, but it can be sometimes because it can be very slow. And if you get the disease when you're 30 and you live to 90, you've got a lot of years of hand fibrosis. Treatment, we have drugs like methotrexate, mycophenolate, rituximab, and a drug called tocilizumab. None of these are they're not TGA authorised, That's not a problem in Australia, luckily, because the PBS, our funding system, allows us to use methotrexate and mycophenolate without that registration. And that's essentially a funded item, just a normal PBS script. The other drugs are not available. Rituximab also is available. It's an infusion drug. So you have to be admitted to hospital, usually a couple of times, and then every 6 months. And it's free on the PBS. Also not licensed for use like this, but well established as a treatment. Unfortunately, tocilizumab is not available because it's really expensive. It is available from a public hospital if you get your local high-cost drug committee to say yes. Obviously, there's a lot of competing people saying, could I please have this expensive drug for my patient? And they somehow have to work out how to fund that because that's not funded out of their allocation from the federal government. In private, you can pay for that, but you're talking about $12,000 a year. So it's not cheap, but it can be effective. If you had some sort of health fund who'd lost the plot, they might fund that as well. And I say that a bit tongue-in-cheek because occasionally the smaller health funds, say the occupation-specific ones, I don't want to name any by name, but they can help with that at least partially. In my experience, the larger health funds, there's a no chance.
Do we know the prognosis of these patients in general terms?
Well, it's a lot of, on average, if you have rapidly progressive disease, you're highly likely to lose 10 to 20 years of your life. So you see people, and it tends to be quite disparate. You see people who die within 5 years or within 1 or 2 years, to be honest. And then you see other people well alive and completely normal 30 or 40 years later. And I'm just thinking about a patient who died of mine about a month ago. When I met him, he had very severe disease. He'd been looked after by someone else for quite a while, and he was that farmer that I mentioned earlier, and he had disease for a long time before he did anything about it because he could still function. And it got to the point where he couldn't function properly. He went and saw someone, and that was a lot too late. And he had involvement of his heart, relatively rare complication. And at that time, when I saw him, I said, you're going to be unlikely to make Christmas this year. I think it was about June. You need to get your affairs in order, and this might well be your last Christmas. That was 5 years ago. So even he, with all his complications, managed to live another 5 years with a truly dreadful disorder, still with a reasonable quality of life, severely impacted, but he still drove his tractor.
So if we're looking at the general people, not progressive disease, and just scleroderma as let's say diffuse, what's the average prognosis for those patients?
Hard to say, but I'd say that they, on average, you'd probably lose at least 10 years life expectancy. Largely because if they get other complicating factors, so in other words, if you've got a tight chest where you can't quite expand your lungs as well as possible due to the skin on your chest or back, then if you happen to get, say, influenza, you're not going to be able to breathe as well as someone who next door who doesn't have scleroderma. And so it's not actually the scleroderma that's causing the problem. It's when you get another issue. And even a bad cold, like a virus called RSV or rhinovirus, if you can't breathe as well, then you can get secondary pneumonias. And then, of course, with a pneumonia, if you can't cough because your chest is tight, you could well need to go to hospital, and then horrible things might happen.
If we look at the localised version, does that affect life expectancy?
Yes, because at about 10 years, there's an increased risk of pulmonary hypertension in the localised version. Now, we don't know why that is, but it is, once again, alludes to the issue that the onset of scleroderma might be related to the endothelium fibroblast interaction. In other words, scarring around blood vessels leading to damage to the skin somehow, or those fibroblasts go off and do something to the skin. And so that decreases your life expectancy. Luckily, about, when I was with Registrar? 17 years ago, there were discovered a group of drugs that were actually invented for blood pressure, but they're actually hopeless for blood pressure because their trials show they didn't lower blood pressure. But luckily, those drugs were invented because they actually treat pulmonary hypertension. And we have, I think there are 3 or 4 drugs, and now there are about 6 drugs for pulmonary hypertension. And so there are 2 groups of people, or 3 groups of people with pulmonary, 4 actually, with pulmonary hypertension. The autoimmune ones, and scleroderma gives you pulmonary hypertension, but so does a disease called mixed connective tissue disease, which we don't need to do a podcast on because it's, 1 in 5 million or something like that. Wow. They get pulmonary hypertension, and the weird thing is they respond really well to treatment.
If someone with localised scleroderma 10 years potentially has pulmonary hypertension, are we considering that we need to do things like spirometry in those patients or lung function test?
We would do lung function tests in all patients with scleroderma.
Right, okay.
Every single patient gets a yearly test, and we tell them, because it can come on rapidly in some people, that if you're getting short of breath during your activities where you usually don't get breathless for more than 2 weeks, which is not explained by anything else, you contact first your GP and or your specialist.
So even localised should be seeing a rheumatologist and immunologist?
Either. You don't see both. Too many cooks is never good.
Just looking then at, with all of this, there was a mention of resistant disease. Is that part of the progressive phase?
Yes, it tends to be. So we do have more drugs now, but there are plenty of people who do not respond. And the other part of scleroderma that there's 2 other parts that are bad. Well, there's multiple parts that are bad. In fact, there's nothing good. But the things that we can interrupt in treatment are the pulmonary fibrosis, so scarring in the lungs. Many patients with scleroderma have that, but it's not progressive. But if people have progressive disease, they're getting progressively short of breath over let's say 6 months. We interrupt that with treatment, and now we have several treatments for that. The treatments are far less than brilliant, but at least now we can show they actually work in some patients. But some patients would get such severe pulmonary scarring that they end up dying from that disease. We know some people get cardiac disease. There's no studies at all because it's just too rare. It's associated, as you might expect, with very high mortality, sometimes from the heart not pumping properly, but sometimes from arrhythmias, the heart going into funny rhythms. You can get gut involvement. We've got no specific treatment for gut involvement, and that's quite common. It can be slow, it can be fast, it can have reflux, constipation, diarrhea, you name it, almost any symptom. And it's a dreadful part because all we can try and treat or sort of palliate with the symptoms, not palliate the patient, but palliate the symptoms, is with various medications, but often they are well less than great.
Are there any final bits of advice or some comments about scleroderma that you'd like to leave for our listeners? We
don't know many risk factors. We know that smoking pretty much increases every single autoimmune disease except ulcerative colitis, where it actually sort of semi-treats it. And that's because nicotine has an effect on the gut. We don't advocate people with ulcerative colitis smoke, by the way. They shouldn't. No one should smoke. And silica exposure. So if you look on concrete packets, those big heavy things that you do a bit of concreting with, it often has a law company, a legal firm that says, if you get tightening of the skin, call us. And so we know if you don't wear masks and you're concreting regularly, you've got an increased risk of scleroderma. Now, the risk is not high, but it's a real risk. And the same thing with silica miners. And so we know that around silica mines, not been shown in Australia, but has been shown in France, there's an increased risk of some autoimmune diseases. And that we know it's true because the frequency goes down as you get further and further away from the epicenter of the mine. Yeah. So we know, but that's it. That's our sum total of risk factors. So it's a very hard disease to understand. Even the experts don't understand it. It's a hard disease to treat, so I'd strongly recommend not getting scleroderma.
Dr. Daman Langguth, I want to thank you not just for the information you've shared with us today, but the next task on my diary was to look for a needle in a haystack, and now I'm relatively confident having compared that to your work with scleroderma.
Thank you so much.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts on social media. Dr. Travis Brown can be found on X. His username is @Dr. Travis Brown. That's Dr. Travis Brown. And Steve Davis can be found on LinkedIn. Go to linkedin.com/in/TheRealSteveDavis. This has been a PathNotes Proprietary Limited production.